becomes a little bit less every year, and our patient population gets bigger. And I can sleep more at night because you have less post-op problems, but people get better with non-surgical solutions. It's much easier on the patient, much easier on me. I have to treat myself too, you know. So if you look at the toe, those are the main problems. As you come back on the foot, you can have problems, as you were saying, problem with pain in the ball of the foot. Now the ball of the foot has two different connotations. We're going to look at the bottom of the foot. There's the big toe, the second, third, fourth, and fifth toe. You know what this toe is called? It's called the third toe. I just told you. Did you guys forget already? This is looking at the bottom of the foot. And the problems that you can get on the ball of the foot. The ball of the foot can either be here or in the middle. It can be either one. If it's in the ball of the foot here, it tends to mean there's two little bones that can get inflamed. You can have a problem with a bunion or an inflamed joint. You could have gout there. We do a lot of work with gout. You could have those two little baby bones there that could be fractured. Whenever there's pain there, we have to look at your foot, your skin, your nerves, and x-rays, very important. If the pain is in this part of your foot, we need to get an x-ray, make sure there's no stress fractures. You could have an inflamed joint because your foot flattens too much and puts too much pressure on the ball of the foot. You could have an inflamed nerve there called neuromas, which we have a little brochure on. And those are the most common things. Also, we can have on any of these areas, on the bottom of the foot, deep calluses, warts, foreign bodies, tears in the skin, lacerations, same thing. And we need to be able to handle all those things. As we come back into the foot, if you have pain over here, you can end up with, or in the toe, you can have what's called a hammer toe. If your toe isn't straight, toe sits like this, the shoe rubs on your toe and you get inflammation, you get a painful corn on there. The treatment for that is to trim off the corn, pad it, make sure your shoe is deep enough. We get x-rays on it, see if there's bone spurs. If you can't treat it with proper shoes and with trimming and padding, then we look at straightening of the toe. But we have to see the x-rays to see where the crookedness is coming from, do the appropriate procedure, and straighten it out. We do most of our surgeries in surgery centers. The very minor surgeries we do in our office. The more major ones we do in the hospital. I'm on staff at Brotman, I'm on staff at Cedars, and used to be other hospitals, but kind of keep life simple. Can't spend all your time in the hospital. So as we come back in the foot, we treat a lot of problems in the arch, a lot. Particularly people who are runners, racquetball, aerobics, many different conditions. If you have pain here and usually extends into the arch, it oftentimes is something called plantar fasciitis, which is a real big fancy word for inflammation of the ligament on the bottom of the foot. And sometimes to go along with that, you'll have in the heel itself, this is called your calcaneus, which is your heel bone. Sometimes you'll have a big old bone spur on your heel, and that continues like that, and that's your ligament on the bottom of the foot. If you have that, we treat that with splints, arches for your shoes called orthotics, sometimes cortisone shots. We refer to many, many, many physical therapists. If that doesn't work, then we have to surgically fix that. Now, a cousin to that is Achilles tendonitis. The reason I say it's a cousin is because very few people realize that your calf muscle becomes your Achilles tendon, and then that becomes melted in with the lining of your heel, and that becomes continuous with the ligament on the bottom of the foot. If you have this or you have that, we teach people how to do Achilles tendon stretching and all the other treatments such as night splints, physical therapy, cortisone shots, arches, good shoes are all very important for that. Again, if that fails, then we're looking at surgery. I've never had to do surgery for this, unless there's a spur in the back of the heel I've had to do. And on these, I have to do surgery less than 10% of the time. Way more than 90% of the patients get better non-surgically on this condition. Now, as you come up higher on the foot, you have the ankle. We treat ankle sprains. There are ankle sprains that involve only your ligaments, and there's ankle sprains that involve your bones. If it involves your ligaments, unless the person is going to be a very high-powered athlete, we typically treat it with casting for 6 weeks to let the ligaments heal, and then refer you to a physical therapist so that they can strengthen your ankles back up. Your ankles are stabilized by ligaments, bone-on-bone contact, and muscles. The only way to reconstitute the ligaments is to let them rest and they heal a little bit. If it's really bad, you have to have them surgically fixed, which I've never had to do. And sometimes, if it's a high-powered athlete, they'll actually take parts of muscles and very creatively reconstitute ligaments that got ripped. But that's a very small number of the population. Typically, casting and strengthening and physical therapy, and afterwards, arches to give less need for side-to-side motion of your foot is very helpful for that. And then as you come up higher, we treat a lot of patients that have shin splints, which is pain in the front of the shin with jumping sports, basketball, aerobics, bicycling, that type of thing. We also treat a lot of patients with what's called runner's knee. And when you have runner's knee, shin splints, we use physical modalities such as ice, anti-inflammatories, orthotics, physical therapists. A big part of what I do with that is orthotics. And a lot of chiropractors and orthopedists and GPs refer me patients for that. I happen to be, like I told you earlier, I've been a runner for 40 years. So I've had most of the running injuries. So I've run 15 marathons, hundreds of 10Ks. So I've had a lot of experience with running, cross country, track, a lot, thankfully. And as you go a little higher, we get patients who refer to us from orthopedists and chiropractors with hip pain, low back pain, even neck pain. If they have ruled out that there's any primary bone problems, and if the patient has problems with their walking that shows that there are shock absorption difficulties, leg length differences, too much pronation of their foot, and we work on improving their gait with good shoes, as I showed you, inserts for the shoes called orthotics, and after extensive measurements, we'll give recommendations for stretching muscles that are tight, strengthening muscles that are weak, and trying to get everything working as normal as possible. So that's kind of in thumbnail or a toenail sketch what we do. Walking and hiking. I just want to make a little note about hiking. Anyone here hikers? Okay. I'm a big runner. I do some hiking. When I do hiking, I use poles. That's not my phone, is it? So, and take out your hard candies and open them up before the performance. Everyone laughs when they go to the music center and they say that still. You know what I'm talking about?
No, because that thing echoes.
It cracks me up.
Yeah.
The funny thing about it is that people laugh still. Oh, open my candies. So when it comes to hiking, in fact, my buddies and I are supposed to do a Mount Baldy hike this Sunday. I just love using hand poles. Not only does it give me better stability, but I find after the workout, I got an upper body workout. So that's just kind of a side note. It's really not a podiatric discussion, but I also think it's safer. When I'm coming downhill, it gives me 4 points of stability instead of 2. Be kind of your feet. Be kind to your feet and your body, and you'll be